The biggest predictor for recurrence in colon cancer is the stage. And the stage relates to at least two elements, the T factor and the N factor, so number of lymph nodes and the depth of the tumor. The early stages, stage 1, and what we call low risk, stage 2, those patients typically get cured by surgery alone, and there's no benefit, at least, from administering chemotherapy. For those patients who are high risk stage 2, so those with T4, and stage 3, meaning lymph node positive, those are the patients who will need adjuvant chemotherapy because of their high risk of recurrence. There's also the element of microsatellite status. For MSI high patients, those patients tend to do better and the risk of recurrence is lower. Nonetheless, they do seem to benefit from adjuvant chemotherapy. And for those patients, fluoropyrimidines alone do not seem to confer much of a benefit. Those patients seem to benefit, though, from a larger study that was a meta-analysis. A number of studies looked combined together showed essentially that there is a benefit with oxaliplatin and a fluoropyrimidine in those patient populations with MSI high, again with high risk of recurrence, although they remain better prognosis. And then there's the age. The age of the patient matters. Oxaliplatin seems to be less beneficial for patients who are older than 70 or 75. Those are the patients that you preferentially treat with a fluoropyrimidine alone, especially those above 75. That's a strong consideration. There's also, of course, other morbidities. You want to start the patients within 8 weeks from the surgery. Beyond 8 weeks, you start losing benefit from the treatment, and arguably you probably wouldn't be concerned much about a benefit for treatment, and those patients beyond 8 weeks may not benefit from having treatment. In terms of the duration of treatment, that has been addressed by the IDEA trial, which is a composite of 6 large randomized phase 3 trials. In the adjuvant setting, patients had either FOLFOX or CAPOX, depending on the study that was looked at. Some studies actually included stage 2s, high risk, at least stage 2s plus stage 3s. So this was presented and then published recently in New England Journal of Medicine. And then last ASCO, we had an update about the high risk stage 2, meaning the T4s. When we look at the cumulative data, remember that IDEA is a non-inferiority study. What comes clear is that from the statistical standpoint, the study did not reach its primary endpoint, meaning it was not non-inferior. But it wasn't proven to be inferior as such or superior in any shape or form. It was not non-inferior and remains in an area of uncertainty. When you start breaking down essentially the high risk, meaning the T4s and 1Bs and above, and then the low risk, what's clear is that for the low risk, 3 months suffices. 3 months is enough with capecitabine and oxaliplatin. With FOLFOX seems to be inferior when you give it for 3 months versus 6 months. And so at this point of time in our practice, patients will receive capecitabine and oxaliplatin, and we do not advocate for FOLFOX, and we do not administer this in our patients. Now, the caveat with CAPOX, it's a little bit more toxic, but you're giving it for a limited amount of time, for 3 months. For the high-risk patients, CAPOX retains its non-inferiority. When you combine the two, CAPOX and FOLFOX, is when you actually somewhat lose on the non-inferiority side. For those patients, I still recommend capecitabine and oxaliplatin for 3 months, and then for those patients who decide to continue through to 6 months, I would go with capecitabine alone. I don't think that there is any much of a benefit from oxaliplatin continued beyond 3 months. So for low-risk patients, capecitabine, oxaliplatin for 3 months. For high-risk patients, the same, capecitabine, oxaliplatin for 3 months. And for select few after discussion, you could continue for 3 more months with capecitabine. A reminder that at the end of the day, from the chemotherapy component, The fluoropyrimidine is responsible for about 15% added benefit to the 50% we see with surgery, rough numbers. And then oxaliplatin only adds 3 to 4%, but also adds significant neuropathy beyond the 3 month, as we've seen from the IDEA and other trials. So overall, there's really no need to continue oxaliplatin beyond 3 months. When MSI is high, we check for BRAF typically, because that helps us essentially decide whether to go down the path of checking for Lynch, although now in our clinic at least, we screen universally every patient for germline alterations, so that has become less of an issue. In all frankness, you really do not need to do that other than MSI and MSS or MSI high. BRAF and KRAS and NRAS, of course, have some prognostic significance, but they don't change our treatment algorithm in the earlier stages of the disease. Of course, they become much more important in the later stages. Understanding that for most of these patients, if we put the whole high-risk stage 2 and stage 3 together, about half of these patients, maybe a little bit more than half, will never have to deal with any systemic therapy beyond their adjuvant treatment because they will not recur. It's the other 40 to 50% that will recur, and then that will have to deal with these treatment options. And for those patients, the status like BRAF, RAS, HER2 become important. So we don't do these routinely on all patients with earlier stages other than the microsatellite status.